Welcome, everyone. We'll just wait another moment for folks to join. Okay, great. Welcome, everyone, and happy October. I hope wherever you are that you're enjoying the festivities. Today, we're so excited to hear from Dr. Hilary Lum and learn about engaging key partners in palliative care research under the hood of co-creation work. Just a few housekeeping items. Attendees are muted and video cannot be turned on. However, we do wish for you to engage with us by sharing your thoughts in the chat and using the Q&A feature, which is a button at the bottom of your toolbar to ask us your questions. So along with Dr. Lum, we also have Dr. Catherine Pollack representing the PCRC's Executive Committee. And so I'd like to turn it over to Dr. Pollack and ask that she please formally introduce our speaker.
Thanks, Naomi. Good morning, everybody. I think it's morning for everybody, unless you're in Europe. It's my pleasure to introduce this wonderful speaker. I've had the pleasure of working with Hilary, so I'm really excited about her talk. She's a geriatrician and palliative medicine physician. She completed her MD and PhD at the University of Wisconsin, followed by internal medicine residency at the University of Pittsburgh Medical Center and geriatric and palliative medicine fellowships at the University of Colorado. She provides care for older adults and their families of choice seeking to improve care and well-being for older adults with serious illnesses. Her research focuses on designing real-world interventions in partnership with older adults and care partners. Her work includes interventions to improve advanced care planning, use of the patient portal, and care for persons living with dementia and their family care partners. She's a PI or site PI related to multiple clinical trials, focusing on improving care for persons living with dementia, and she mentors trainees as a co-director of the T32 Palliative Care and Aging Fellowship. So with no further ado, I'm going to turn it over to Hilary. Thank you, Hilary.
It's so great to be here. Thank you for the invite. Thanks to all of you for logging in and looking forward to our discussion today. So I really enjoyed putting this talk together. It actually is my #1 talk for this entire year. It's new content, and I'm looking forward to feedback on it. So today we'll think about illustrating options for multi-level stakeholder engagement, identifying resources for co-design that I hope can be helpful to you in your work, considering opportunities for diverse funders, and co-creation strategies. As we discussing challenges. So a disclaimer, I am self-taught here. I did not take a formal course in this, and this really is the see one, do one, teach one. Interesting, and also is moving forward itself. So with that, I'm going to try to provide sort of a large context, and I'm going to share some definitions. Those of you who have had formal training in some of the things that we're talking about here, please extend grace. Recognize that there are many definitions for many of these things, and I hope we can share knowledge about what we're going to talk about today. So thinking about the fact that there are a lot of terms, I just put a handful of them on this screen, and you can see that there are many: co-design, co-creation, human-centered design, UI, UX, design thinking, as well as others, perhaps a broader umbrella of community-based participatory research, participatory action research, stakeholder engagement. So there's lots of terms here. And so for today, I'm going to just give us a starting point for our discussion. And I'm very interested in other frameworks that you come across. So one starting place to think about is that there is a continuum of community or stakeholder engagement, and it can range here on the left from perhaps outreach with some of those activities described here in bullets, and then increasing levels of community involvement in whatever the goal is. And as you progress to the right, it becomes increasingly a shared goal, something that more people care about together as we're getting into consulting, involving individuals in the process, collaborating, and shared leadership. So I know a little bit about community-based participatory research. I would consider that here far on the right in shared leadership, where there really is setting of the agenda from community-based perspectives. I really encourage you to watch Renee Elk's webinars as part of the PCRC series to think through community-based participatory research. Today, I'm going to highlight co-design opportunities, which I think can actually fit in the categories of a consulting frame, involvement, or collaborating, sort of on this spectrum. So not going to talk too much about CBPR, and instead going to think about co-design opportunities. It's also important to think about, what do I mean by stakeholder engagement? So again, this is a term where multiple people have multiple different definitions. We could think about it as bidirectional and longitudinal between stakeholders and researchers in our context of palliative care research, to then inform decision-making about different aspects of research. What are our priorities within research? How do we actually design and conduct studies? How do we disseminate our findings? And I think stakeholder research often involves multiple different stakeholders. I'm going to come back to this website a couple times, dicesmethods.org. And as you're listening in, I encourage you to have a piece of paper, jot down things that you hope to learn more about. I'm going to be covering a lot of ground, introducing some of the tools that have worked for us in sort of this under the hood perspective. So please jot down things that you want to spend some time following up with and learning more about. So now I'm going to focus in, what is co-design? Spent some time on Google thinking through co-design. There are lots of different definitions for co-design also. I think as one that resonates with me is the meaningful involvement of end users in research. So co-design is thinking about a product or an intervention or something that then we hope is useful to people that it's designed for. And I think from a co-design perspective, designed with. Key components of co-design are listed here. I grabbed these from a website. Again, there are many different websites from both a research perspective as well as design perspective and nonprofit organizations and governments that seek to engage the public in co-design processes. So we'll sort of be hitting on a couple of these core principles of co-design, such as intentionally involving the end users in designing solutions, perhaps postponing design decisions until gathering feedback, synthesizing feedback from target end users into the insights of designing what you're designing, and developing solutions based on feedback. So I provided you with a working definition of co-design. Again, I'm going to take a step back and just acknowledge how complex this field is. This is a paper called Co-Design Evaluation and the Northern Ireland Innovation Lab. And so as we look at this figure on the right, this paper synthesized some input from a book by Sanders and Stappers, thinking about where does co-design fit among the landscape of a lot of different aspects of a design. And for myself as a health services researcher, this figure here on the right is new to me. You know, it's different than the disciplines that I've had some training in. And so I just provide this, that especially as we work across disciplines, which is terrific. It takes some time to even think about what is our shared language, what are our shared methods that we're doing. So here's my commentary as I think about co-design. While co-design may have a specific definition in fields other than health research, research co-design may be more variably used in health research. So I think there's also a humility that I'm aware of needing, in that when I say co-design, the person that I'm chatting with may have a different working model of what co-design is. This review sort of reflects that. There are systematic reviews looking at the use of co-design in health research. So I just wanted to highlight this paper for those of you who may want to learn more about how co-design has been used in different health studies. Some of the recommendations that came out of this synthesis were that training participating end users in research skills is important. Having regular communication between researchers and end users is a key aspect, setting clear end user expectations, and assigning set roles to all parties. So these were some of the commonalities across the different health research studies that used co-design. This is a table from that paper, and I highlight this because, again, it's showing the diversity of terms and how some of the studies then also helpfully provided a definition. So I think one takeaway for me is when I'm developing a study and then disseminating it and want to be clear in publications, what do I mean when I talk about co-design or patient and family engagement, etc. So there are some examples about how other studies have defined the type of engagement that they've done. So now I'm going to get into some sort of practical aspects of co-design, questions to consider. We're going to walk through these in 3 different case studies, and I'm going to highlight some resources that I have found helpful and might be resources that you want to follow up on. So we're going to talk through sort of what is the purpose, what are the co-design needs of your project, who are your partners, and what role will they play in that project, especially thinking about the continuum from outreach to consulting to involvement to collaborating and even to shared leadership. What process of engagement will you use? And we're going to dive deeper into some evidence-based stakeholder engagement resources. What are the products that you hope to develop? And that could be the product of your research project, as well as products that will help implement your intervention or help what you have co-created to go farther. You'll often end up co-creating those things as well. And then funding. What sources of funding or other resources in your environment are available to you? I've learned a lot about what is available, especially through some of our dissemination and implementation resources on campus. I wanted to take a minute to think through a framework for stakeholders. So this was published in JGEM in 2012. The 7 Ps, thinking through that as we do health research and are seeking to have something be perhaps as pragmatic or real world as possible, and perhaps be as sustainable as possible or scalable, we often have multiple stakeholders. So several categories are listed here. You may engage some or perhaps all of these in different phases of your research design. So now getting into 3 different palliative care case studies. So the first one, improving communication in dementia care. This one is really going to focus on the planning phase of research or priority setting. So our purpose here in this particular example was to identify priorities of persons with dementia and family care partners related to how they prefer communication with the health system, especially using digital tools, which was a focus of our work. And you can see that this was not CBPR because I wasn't able to fully have it be a blank canvas to understand what the priorities are, but instead I sort of put in some guardrails, or I sort of defined the area as the researcher and then asked individuals to participate with us to give their input. So we'll walk through some of these different aspects from partners and process and products. We'll tell you a little bit more. So I mentioned the overarching goal, and our context is an academic health system. And so we really ultimately are focused on building capacity for pragmatic embedded clinical trials. This work was funded by the NIA Impact Collaboratory, which some of you may know is really interested in developing interventions in the real world that could be then tested in clinical trials. So I'm going to focus especially on our first of 3 goals, but you can see that each of the goals in how we proposed this 1-year capacity building effort focused on engagement in different ways. So I'll show you examples from our patient and family care partner experience. We convened a patient and care partner council. So this, you'll see, is something that requires a fair amount of time, and you want to budget appropriately in terms of your own time, your research team members' time, and you'll end up wanting to partner with a number of community organizations or other clinical partners so that you're able to identify individuals and invite them into participating in a council if you're interested in setting it up. Once we had the council established, which I'll tell you more about in a video, we then thought about, well, what are we going to do in our monthly meetings to achieve our goal of knowing more about their priorities related to communication. So here's a resource. We use this website, dicemethods.org. This is put together by our Colorado CTSA, and this collects evidence-based strategies for stakeholder engagement. I'm showing you a screenshot of the website. There's a video there that provides some helpful definitions of stakeholder engagement and then how to use this navigator. Here's just sort of a sneak peek of some of the stakeholder engagement methods. And I show you this because you can see that there are a number of different hyperlinks and types of stakeholder engagement. Each of these then have information about how you would do this, key references, how much it might cost. So it can really help if you are project planning or grant planning to think through how you might want to integrate engagement activities into your research project. I've had experience with appreciative inquiry, community engagement studios, which I'll show you about in one of our case studies, Delphi technique, human-centered design, stakeholder panel advisory committees as examples. So coming back now to our first case study, what did we do with memory tech? So we went to dicemethods.org, thought about what methods might work, especially since in the time of COVID, we had some gatherings that were in person, some that were virtual. So we chose to do a World Cafe activity. We also did some things that were virtual using a Google Jamboard. We integrated speakers from community organizations as well as content experts, because we asked at the beginning what type of content our memory council would like to hear from to better equip them to be able to participate in a meaningful way in terms of giving input. So just wanted to show a couple examples. Here's from our virtual Jamboard. We asked about communication, and individuals can put up sticky pads and we can write. And so it's a way of sort of having ongoing note-taking. We also, I think, in a way to inclusively ask everyone to participate and sort of get a pulse of the room, we asked this, what's one word that needs to be true about communication? And then created a word cloud for it. So as some of you may know, as you've experienced this, you can sometimes have different types of engagement, and sort of a one-word question can help individuals synthesize what they're thinking. So I want to just show you briefly this video. We'll watch the first minute.
I'm afraid we can't hear it.
Oh, thank you. Let's see if I can, let me just briefly stop share and then I will reshare with audio and clip. Thank you for that. Sorry for the technical piece. So I won't show us the whole thing, but basically I'm going to have this introduce memory tech as a council.
Clinical research to improve dementia care. We believe in improving the quality of dementia care begins with understanding patient and care partner experiences. I'm so thankful to our patients and family care partners, UC Health Clinical Partners, and the Healthcare Systems Scholar Program. Our goal is to improve communication and care communication in dementia dementia care through useful health information tools like a healthcare portal. We used 3 strategies. Strategy 1, we wanted to understand the needs of patients and care partners. We convened a group called Memory Research Partners Caring Through Technology, or Memory Tech Council for short. The Memory Tech Council includes 18 patients and care partners from diverse backgrounds. They have experiences with healthcare, caregiving, and being a patient themselves. The group discussed their needs and brainstormed how the healthcare portal could help persons with dementia and their care partners. Strategy 2, we wanted to
just wanted to give you like a flavor of some of the products that we as the team created to highlight the involvement and engagement of our research council. This slide also summarizes sort of the 3 pillars of the project where we're seeking to integrate their input into how we can identify individuals within the health system. Then you heard a little bit about partner input on refining digital tools through the patient portal, which we're working on. And then also we want to move forward in terms of how we can measure dementia care partner engagement. So that is the first case study that I wanted to show you, where we really, in 1 year time, had 7 meetings across about 6 months for gathering this Memory Tech Council to give us input and help us co-create a few interventions, but really it was fairly upstream in terms of identifying priorities and for me trying to listen well to the feedback that they were sharing. So I'm now going to transition to our second case study, thinking about implementation, designing tools for implementation. And in particular, we're going to look at advanced care planning tools. This was funded by the Colorado Health Foundation. They are a health foundation local to Colorado and had a specific call for patient portal projects. So I think this is an example of how that was not about palliative care at all, or about advanced care planning or co-design. However, it was something that we were able to think about how we could integrate co-design principle funding opportunity. So a little bit of background to set us up for this is basically in 2017, our health system didn't have any information about advanced care planning in our patient portal. In Colorado, we're able to have a medical durable power of attorney, the process to identify a decision maker, be completed fully online because we don't need a witness or a notary. So I very much recognize that that's unusual and specific to Colorado, but there certainly may be other opportunities where you can think through what could we imagine might be possible, and how could a co-design process help us to get there. I wanted to highlight really a lot of different people as partners were involved. I've grouped them into patient and family advisors, clinical operations, healthcare team members, especially in this clinical operations box. There were many meetings, many opportunities to sort of learn the culture of the different committees. I think also important when you're working with an operational partner is to think about what could be our phased approach. We thought through first a website and an online message. Phase 2 was when we actually implemented the ability to complete the medical durable power of attorney form. And then phase 3 was also wanting to then display those advanced directives in the portal. This work is generally speaking publishable, and I think JMIR, some of you may have experience if your work is at the intersection of digital tools or mHealth and using co-design, the JMIR family of journals is very interested in this type of work. I wanted to use this case study to highlight a key principle that I've been learning about, which is the minimum viable product. So this is this concept that as a researcher, I may want a lot to happen in an intervention. I may want to have a lot of functions I may want it to be very comprehensive. However, that may never be able to be implemented. So I think using a co-design process and thinking about perhaps the compromises or what could be the minimum viable product that helps us have function, safety, be reliable, be usable, have empathic design that is workable enough for the end user. So our medical durable power of attorney, especially in its phased approach, really reflected this minimum viable product. Would we have liked to have a pulse form or any number of other things? Yes, certainly. However, if we had waited to get all of those things together, we never would have been able to implement where we started. I also want to highlight some of the tools that you might end up creating, like to go along with your intervention. So we engaged with UC Health Media to create a patient-focused postcard to highlight the fact that the eMDPOA existed. We also then built the website and were able to film a video. This video highlights leadership commitment. Our CEO is part of this, saying how important advanced care planning is to her. And it was very important for me to engage with UC Health Media in writing the script and having it be filmed. And so there's a lot that is important in sort of navigating products that you hope to be part of the health system, because they have their brand, their audience, what they are able to support. I also did qualitative interviews. So I think from the research perspective, one way that you can help with implementation is by gaining iterative input along the way to understand feedback from your end user. So an individual who is 30 said, being able to go online and kind of do a little research myself, it made me more comfortable with it. And then I could bring up that kind of conversation. So I think it's absolutely necessary to have it online. These quotes, I think, in the stories of how individuals are using your tools, especially as you're rolling out iterative versions, are very powerful. It's also important to evaluate as you go. And so this is an example of how we were tracking our use of the medical durable power of attorney through the patient portal, and use slowly increased. Then it was very interesting from a secular perspective. COVID happened in March 2020. The patient portal use was suddenly the place where individuals could sign up for COVID testing and then COVID vaccination. And so we experienced the bystander effect of simply having the MDPOA tools available to patients who had My Health Connection accounts. Then patients were also taking the opportunity to complete the MDPOA. It has been important as we have partnered with operational leaders to periodically provide highlights of this work. So shown here on the right is a program infographic that we created in PictoChart. You may use Canva or other ways of creating infographics, where we would routinely update this, every quarter or so, and I would share it with CEO and other leaders, just to highlight how individuals were finding value and the reach of the MDPOA tool that they had supported implementing. So I think that this project hopefully highlights some of the different tools that you may want to consider building as you're putting together your interventions. Health systems are complex and a lot happens. And so the more we can have it be front of mind or sort of seen without being intrusive, the better. So here's the final case study. This is something that we just completed this year with my collaborators, Matt DeCamp, Kate Yattel, and Stacy Fisher from the PCRC. We have had this wonderful journey of co-creating COVID-19 vaccination messages. And I'll show you some of the unique tools that we used in this co-design process. This was funded through a U3 supplement, so understudied, underrepresented, and underreported. I want to pause here. I think Funding for creative work, creation work, can sometimes be difficult in standard. Certainly the R01 can be hard. I think there's some space for it sometimes within the R21 mechanism or a K award. However, I've really experienced success with supplements. So the supplement challenge is you have to go fast. It's 1 year, but the opportunity is it's that chance to build onto a project saying that you want to gather individuals who are knowledgeable end users and co-create sort of the next phase of the research. We can talk more about funding. So our key partners here are home health aides. We engaged 4 different hospice and palliative care agencies through the PCRC. You can see the leaders here, as well as some of our co-investigators who are experts in vaccine messaging. And here I want to introduce our frame and use of design thinking. Design thinking is a conceptual framework for rethinking and solving problems. There are a couple of different descriptions and displays of it on various websites. I'm showing one of them here that emphasizes 3 phases: understanding, exploring, and then materialize. And you can see that that is sometimes broken up into 5 or 6 sections: empathize, define, ideate, prototype, test, and implement. And I'll walk you through how we applied those phases in our process of wanting to understand and improve COVID-19 vaccine messages so that they can reach home health aides. We chose home health aides because compared to other members of the healthcare system, their voice is less asked for. So we really wanted to elevate this invisible workforce and what messages would appeal to them and resonate as they're doing their frontline work of caring for individuals with serious illness and their families. So the first phase of understanding, we conducted qualitative interviews with home health aides and leaders. Then I'll introduce our use of a community engagement studio as a structured mechanism for exploring how we might develop messages and prototypes. And then we are disseminating through a practical, culturally concordant with sort of a home health context, a communication tool to improve COVID vaccination. So here's a little bit about this first aspect of understanding and empathizing, defining the problem from the perspective of our end users, of home health aides and administrative leaders. We found that there certainly is a communication gap between the information that may come from the leadership of a home health agency and the information that the frontline home health professionals find would resonate and would be motivating for them in terms of COVID-19 vaccination. So our hope is to elevate and empower the voice of home health aides specific to aspects of message format and message content. And I'll show you how we really sought to embrace this information from the explore phase into the developing and prototyping phase. Over, I think, 4 months, this is an example of our timeline. So we started with that understand phase with interviews, then had one community engagement studio with home health aides. I'll show you about that. We, along that process, engaged a graphic designer and visual illustrator who could be actively developing a prototype and iterating on those prototypes with input from the home health aides and community engagement studios. And together that then resulted in being able to test and disseminate. So I'm gonna again show a video, just the first minute or so, which will introduce the project and specifically will define what I mean by a community engagement studio. We showed this at the first community engagement studio. So the audience is the home health aides. Also, as I'm showing this product, I'm describing a little bit about our process of making this product, including the cost, and we can talk more about how to find resources like video creators and others.
Firstly, we want to thank you. This work wouldn't be possible without this video. Your voices are integral to this project. You're serving as experts in your experiences. What's this project? It's called Engaging Community Hospice Partners to address social, ethical, and behavioral barriers to COVID-19 vaccination for home health aides. We'll describe what this means very soon. As we get started, I'm sure you're wondering, how can I share my thoughts? What's a community engagement studio? A community engagement studio is fancy talk for what we're going to start doing together. Together, you're an expert panel. As researchers, we want your reactions to help home hospice and palliative care agencies develop materials around COVID-19 vaccines. This project aims to create a practical communication toolkit consistent with common cultural beliefs and values among home health aides to encourage COVID-19 vaccination. We'll share what we've learned so far, talking to people like you and some hospice agency leaders and administrators regarding COVID-19.
That's just a little flavor of the video. It's about 6 minutes, and it was what we started the community engagement studio with. I will then show you a few more of the tools we used once we were engaged in this community engagement studio. We conducted 2 of them. They had, we invited 8 different home health aides. They also were attended by a visual illustrator. So we wanted to have these meetings be a place where we could build rapport and where we could communicate clearly and iteratively, let the home health aides know that we were listening well. We wanted to demonstrate that. So one way we sought to do that was with real-time visual illustration. So we have someone who was able to be a contractor with us, who participated in the meetings, helped with creating the agenda so that we could show this at the beginning of the meeting. And then we introduced her and recognized or let people know that Chris would be taking notes visually throughout the meeting so that then we'd be able to see them sort of as we wrapped up. So here's an example of the agenda. Here's an example of what Chris created related to the introductions that the home health aides did at the beginning, sharing where they were from, some of the things that they found really meaningful in their work. And we hope that this helped individuals to get to know one another better. I'll pause here and also note that for the community engagement studio, each home health aide was paid $150 per 2-hour CES. So if they participated in 2, we were able to reimburse them for their time. We sought to have this be at a time that worked for them, and which of course is challenging across 4 time zones. Now I'm gonna sort of give a description of how we moved from the information in the interviews into the co-creation process with input on vaccine messaging and format. So we started by asking the home health aides to respond to some existing messages that we found on the internet. So that is summarized here, where you can see some of the reactions to just what is already out there. Then we moved to where we had asked our graphic designer to come up with some ideas that embraced input from the interviews to be ready at the first CES. And so here you're seeing the prototypes with then the note-taking by our visual illustrator. And so you can hear some of the comments of liking this verbiage, where boosters help your body remember how to resist infection. And this was helpful to be able to show back to the home health aides at the end of the meeting of, did we hear you right? Anything additional to add? And then also to thank them for their input as we then would seek to carry that through into the next prototypes. We asked about different ways of sharing out messages. So here's an example of giving examples of stickers or pins and the input that we received back from the home health aides during the community engagement studio. We heard what they liked. We asked questions of would they wear it. We asked what other swag would be helpful or well received. Here's a summary of some of the other content that we heard from the community engagement studio of key messages that they wanted to ensure that we were conveying aspects of trust and safety, that getting a COVID vaccine is often about caring for others in their community or in their work. And so I just want to show one example of a final sort of prototype that we had iterated and is refined based on input. So you'll see here that there's PCRC logo and some information to the CDC. We heard from the home health aides that they want to know that this information is coming from a reliable source. We also we heard input on the photos being ones that either were from their own hospice, sort of approved photos from their hospice, and so these can be customized, or that they would at least reflect being at home and not in a hospital-based setting. All of our prototypes are now put together into a communication toolkit. So this is an example of one of the products that we created, and our graphic designer was very helpful to us in being able to have this be hyperlinked to Google Drive, where all of the different messages are available for download and can be customized by the hospice agency. That was some of the input that we received from the administrative leaders of wanting to be able to customize to their own organization. So that's the end of the third case study, taking you sort of a whirlwind tour through a couple of different examples of co-design and products that we've made. So I'll leave you with thinking through these key questions as you might be considering how you want to integrate co-design into a research study. And some of my sort of cross-cutting thoughts are that you want to be thinking about how to engage with multiple voices, people who have different perspectives from their backgrounds, to provide formal and informal input to refine your priorities, your intervention, or your implementation and dissemination. We can talk about multiple funding opportunities. I provided here resources, dicemethods.org, but also hopefully throughout, maybe you took note of, like I want to look into whether there's a visual illustrator or a collaborator who could create some of these products, or I need to find, the media team with my organization so that whatever we make can be on brand. And you can be thinking about multiple deliverables, including a number of the deliverables we made were because our partners said, can you create this because it would be helpful to convey the message if we have this available. And some of my reflections, I really enjoy co-design. I think it's the opportunity to be creative and create things that people will use, hopefully. The opportunity to partner with a lot of different people in a lot of different areas of expertise. It's the opportunity to listen and seek to understand what people really need and incorporate their input as best as we can. And then I do encourage persistence. As you highlight important things, you'll often then hopefully be able to find creative ways to have them be funded. So with that, I will invite Kath back on.
Thank you so much, Hillary. That was fantastic. I would love to open it up for questions. I don't see any in the Q&A currently, but feel free to put the questions in the Q&A.
Thank you. I have one question to get us started while everyone types in their questions in the Q&A feature. Dr. Lum, thank you. I really appreciated the emphasis on terminology you had at the beginning of your presentation. These terminology challenges like have been seen everywhere, included in home health. So did you find that that came up in your interviews, that perhaps your sample identified more as a personal care attendant or home care attendant? Did that affect your recruitment? And did you notice any trends with terminology?
Yes, thank you for that question. I think broadly, and then I'll answer specifically. Broadly, just as individuals may not see themselves as a caregiver or a care partner, as we are seeking input from perhaps a particular perspective, asking people to wear that hat, that may not be the hat that they most identify with. So then in particular, thinking about home health aides, we ended up using a couple different words when we were seeking to engage individuals. So sometimes we used direct care workers, I agree, personal care providers, home health professionals. I think we worked to recruit and engage based on relationship, including with our hospice administrator leaders, the PCRC contacts, so that hopefully we didn't get caught up with terms and hopefully we weren't off-putting, but instead we're able to convey who we hope to partner with rather than based on a label.
Absolutely. Thank you. I totally appreciate the need for, scientific literature combining and, defining these terms in a way that makes, makes sense. Would anyone like to ask a question for Dr. Lum?
You made it look so easy.
That's not easy. I will be happy to share many challenges. I, like all research, it is difficult to appropriately resource these types of capacity building projects. So first, you need to convince funders that you can be funded to do this. I think realistically, many of us do this as sort of unfunded because it's the right thing to do. We want to incorporate input at every phase of what we're doing. So I think a tip would be to know your local resources. As an example, here at University of Colorado, Dan Matlock has an existing patient and family advisory council that meets every other month within the Department of Family Medicine. Associated with practice-based research networks, there's a primary care patient and family advisory council that meets. So I think knowing some of your existing resources who are frankly often interested in researchers coming and chatting for 45 minutes to get input on a research study, that's I think a way to start that is more doable, less costly. Because I think, to develop your own council certainly needs research team member time.
Absolutely. Naomi, can you see anything in the chat or the Q&A?
No, last call for questions. In the meantime, I'll just let everyone know that there will be an evaluation coming in your email about today's webinar. Please do feel free to give Dr. Lum feedback in the comments. And next up, we'll have Dr. Jean Kuttner presenting on building a research shop on Wednesday, November 30th. As always, please do complete the survey so we can continue to improve our IDC offerings, and you'll see a couple more IDC announcements coming soon. So thanks so much for attending, everyone. Happy to give you 10 minutes back and take good care.
Thank you, Hillary.